Hi, everybody. Susan Clinton here with my co-host Erica Mello. This is Tough to Treat, episode number 121. So we're moving up the pathway here, getting into the triple digits, and have been here for some time. So we're happy to still be able to bring this, we think, very valuable resource. Because as you all know, it's our passion to help clinicians improve their outcomes and improve their ability to treat these patients that are complex. It's part of our world. We don't want you to be burned out. We want you to be excited and compassionate healers, be the people you were meant to be, and not let the chronics make you sad.
Yes, exactly.
So I want to just make a couple of announcements before we dive into our segment today. And basically what we want you to know is that we want you to come and opt in to toughtotreat.com. Get on our list because all of our powerful information goes out on our email list. That's where we communicate with everybody in our community. We're building a community, and we're building a new community in our podcast subscription, which is the Premium Podcast Club. And that's at toughtotreat.supercast.com. Yeah, go ahead.
No. I was just going to say that I was talking to somebody recently, and don't we all want to get our patients better, quicker, faster, right? We all want to streamline our evaluations. We want to hone in on the driver quicker, right? And so on our website, we have some resources when you sort of sign up for the newsletter. Right now, we have a Clinical Pearls PDF that I wrote about just real examples from my caseload on how to efficiently streamline your evaluation and treatment. And Susan wrote a couple PDFs on sleep, and sleep is so important in chronic pain. And I routinely give those PDFs out to patients. And I think that it's really, it's a wise resource. So I know you all want to up your game, so to speak, and get your patients better and not be frustrated, as Susan was saying, or just get sucked dry at the end of the day. Okay. And these will really help you. So the website is toughtotreat.com, and you will get on the newsletter, and we email every week, and you can read it. You don't have to read them, but there's a lot of great tips that we put in there. And we all want to make ourselves better clinicians at the end of the day. At least I do. So would love to see you in there.
Yeah, so go to toughtotreat.com and opt in, because we're going to be sending an email out soon that's going to have a form for everyone to fill out to tell us what kind of offerings you would like us to see us do. And so we want you to be able to have your voice be heard and come on in and do it. And we'll see you very soon inside the membership as well. Enjoy the podcast. Hi, everybody. Susan Clinton and Erica Mello here with podcast number 121. And today we're going to do a segment on some myth busting. And the topic is going to be pelvic girdle pain in pregnancy. So I'm going to give a little intro here on a few things, and then Erica and I are just going to kind of discuss what we know, what kind of clients we've seen, and what we need to be doing a little bit differently. So basically what we need to pay attention to since the pelvic girdle pain, I can't think of the name of it, the guidelines, sorry.
Yes, the CPGs.
Yeah, came out in 2017. One of the things that we wanted to highlight in that is the cognitive nature of risk factors for pelvic girdle pain. And I say cognitive nature of risk factors for pelvic girdle pain again in a repetition, to understand that this is probably not something that is driven by instability or all those other, or loose joints or relaxin hormones or any of that thing that has been completely dispelled. So we need to get away from, I want to move clinicians up in the world. There's always sometimes a 10-year lag before things that are found in research are actually implemented in the clinic. And so this whole myth busting segments that we're going to do, we're going to be to help elevate us up into the research a little bit better. But some of the risk factors for pelvic girdle pain include work dissatisfaction. Think about that.
Yeah, interesting.
Huge one. A lack of
Hmm.
belief of improvement. They just don't feel that they're going to get better. And why is that happening? Because everybody's telling them that you won't get better till after you have your baby. And that
Mm.
actually doesn't work either, because if this isn't treated well, 30% of the people with pelvic girdle pain in pregnancy go on to have chronic pelvic pain in postpartum. So we need to do something, but clearly telling people that they're unstable and that they have these, ligaments that are distorting their joints is not correct. And so also previous pelvic trauma and a history of low back pain, and also parity. The more pregnancies we have, the more possibility we have for having pelvic girdle pain appear. And some of the reasons behind that is because if you think about it, you have one baby, you can rest when the baby rests. When you have two babies, now you have, two children, the sleep in the house becomes very disruptive. And we know that sleep is super, super, super important for managing pain and symptoms. And it's important to kind of realize this because there's a lot of things we can do to help people. And so we're going to talk about the movement system approach to it as well. But I wanted to bring up and, understand that we really have to pay attention to messages that will decrease fear and catastrophization while
Mhm.
promoting self-efficacy. And it's really important for us and our patients to not, talk about things like, hormones that are unhelpful. Like, first of all, relaxin has been completely ruled out in the literature. It is not changing joints in a way that makes them slip and slide and be useless. That's not
Mm.
what's happening. So the body is built and the pelvis is built to withstand these forces and these changes. So it's not because of joint changes and hormones. Those can create a sensitivity around the joints, but it's not because the joints are at fault or in the wrong position. So we want to think about
Yep.
that. And if people are not sleeping and they're not satisfied with their job and they've got a lot of stress in their life, they're really living in a cortisol driven environment. And when
Yep.
they're living in a cortisol driven environment, that's going to create joint sensitivity. It's going to create joint pain. It's going to create neural sensitivity, because
Mm.
it's one of those, the HPA axis is off. It has to
Yes.
be, because the cortisol is ruling the show now. And it, when we have cortisol riding high, it blocks the ability for us to access serotonin.
Hmm.
So when we can't access serotonin, obviously the stress, the survival brain stress piece is going a little bit higher. And so we want to kind of think about that. So also people will talk a little bit about, the fact that, oh, your posture's all off because you're pregnant. Well, those postural adaptations are normal and necessary. If our stomach is growing out in front of us at a rapid rate for the human existence, if you think about it, 9 months is nothing in the existence of somebody who lives to be 80.
Yeah.
But the rib cage has to move, displace posteriorly. You're going to fall over if you don't.
Yeah.
And, we're going to have a wider base of support. And that's all to balance everything. So we want to think about reassuring that these postural adaptations are healthy, necessary, and normal. And that it's not going to be increase your pain if you breastfeed. And certainly vaginal birth is not going to increase or decrease your pelvic girdle pain. And I think those are some of the things that we're talking about with this.
Yeah. So let me ask you this. So
Yeah.
I have a patient who I don't generally see immediate postpartum, right? So I'm seeing a patient now who I've been seeing her for a long time for chronic neck issues. She just comes in. She is pregnant.
Mm-hmm.
Okay. She is due in 2.5 months. Okay. At the end of July. And she has been complaining of on and off pubic symphysis pain,
Mm-hmm.
coccyx pain, and difficulty sleeping.
Mm-hmm.
So for somebody like me, how do you suggest I manage this or talk to her about this? What language
Mm-hmm.
should I use then?
Yeah. And that's a great question. And thanks for asking
Yeah.
that, because it's the same thing everybody else has out there too.
Yeah. Yeah. Exactly.
It is, and when people are pregnant, there's a lot of agency around the pelvic region. They're going to the
Hmm.
doctor, they're getting, these tests all the time, they're checking their cervix. She's had a baby before or
No,
no?
it's her
Okay, so
first.
first time. So there's always that, that fear. That's like, there's that anticipation. It's exciting. It's a wonderful
Yeah.
time of life, but it's also that the fear. They hear the stories. They, what happens if I tear? What happens if this happens? What if nobody listens to me? There's a lot of that going on. And if she was already having a lack of sleep before, especially with chronic neck pain, then that could be something that could be carried over in here. And now this region is changing and moving. And so the agency around the pelvis has become, more sensitive. So in that, I would talk to her about her nervous system being sensitive. She gets that already. She knows that about herself. The same things that flare her cervical symptoms can be the same things that will flare her pelvic symptoms.
Right. Yes, I agreed.
And so she can understand in that language that, hey, this neural sensitivity is just happening here now because there's some changes going on here, but they're not changes that are not, they're not changes that are harmful. They're changes that are helpful. So your body's doing the normal things. It's just that your nervous system is sensitive, and so it's feeling like, wait, something's a little bit out of control here, and that's driven a little bit more by that, the negative emotions, the negative sensitivity, the negative survival brain kind of thing, like protect, protect, protect.
Yeah. And the funny thing is when I palpate the pubic symphysis, and I really go in there hard. She's not jumping off the table. Yeah. I go in on the tailbone, nothing, and I'm, and she's like, it's not a big deal. I said, well, just keep me, posted. And because I said she had a problem sitting. So I said, you just went you went to your house and you sat in a comfortable car, like a car seat. She had no problem there. I said, well, okay, it's situational, environmental, it's pressure. Yeah. So I was trying not to make a big deal of it, so to speak. But there are people who come in and they're like, my pubic symphysis really hurts. I had a patient some years ago, and that's all she came in to see me for. This was over 15 years ago now. And it was exquisitely sore. And back in the day, I ended up giving maybe what your thoughts are on this, the myth busting around pelvic girdle belts. I popped in Madonna Diane, these pelvic girdle belt. It helped, but, so let me hear your thoughts on that as well.
Yeah, sure.
Myth,
so
right?
let's dive into the pelvic, to the pubic ramus pain.
Yeah.
Because this is pretty, in pelvic girdle pain, it's one of the more common presentations.
Yeah.
But remember, I'm going to remind everybody to go back and listen to the podcast that we did that was titled the psoas triangle, but really
it was recent.
More like the psoas pyramid.
Yeah.
And in that podcast, we highlighted all the neurological sharing in that region. And, pubic ramus pain could actually come from T12L1. And if you think about that, because that goes down and around into the groin area,
right?
And you can also have tenderness of the ligaments in the low back from that.
Yeah.
Because the iliolumbar ligament, iliosacral iliolumbar ligament, also shares neurology with T12L1.
Yeah.
So when you think about the multiple, and then you have to think about the maybe the genitofemoral nerve, coming from the same area, T12L1, and can give us pain into that region. And, so some sensitivities can be set up for sure. Having a real change in the pubic symphysis joint, you have to have like a real event to happen for that to really be off, because the pelvis is super stable. And, because we have pain somewhere does not mean that always is the cause. But when it's in pregnancy, unfortunately, it has been painted as you're pregnant, so it must be because of your pregnancy, and it may be some maladaptive changes that have happened, maybe the way that they sleep on one side, maybe the way that they constantly move, are they carrying their baby over on one side? What are the things that we, so look at this the same way we look at all the claims we talk about. What are the drivers here?
Right.
It could be maybe because they're standing on one leg and they're standing with the other leg. So if they're carrying their baby on their right and it's left pubic ramus pain, they're standing in relative internal rotation on the right, and maybe relative external rotation on the left, or maybe even the opposite. Maybe they're standing a different way. What can they do? And what happens? When do they have their pain? And what can we do to help them learn how to mitigate it? Just like you were talking about with your client in the car. And I think that's so important, is like having her begin to investigate, well, it's not just when I sit, it's when I sit maybe in certain chairs that it's more uncomfortable. And so can you figure out a way to do that differently? What can you put in the chair to make it more comfortable? Can you change chairs? What can you do? It's better in the car. What's good about the car? How long can you sit in the car? How long can you sit? Just like we talked about with some of our clients recently in the podcast is, what's actually happening here is that, are you just sitting too much because everybody keeps telling you to sit down? Oh, you're pregnant, sit down. I mean, we culturally, we still want to do this. We don't, we want to take care of ourselves and feel what we feel. And I'm not saying do not believe them. I'm saying believe them, but not for the reasons we used to think.
Yeah, but with her, I think the physician, the establishment is still telling her that it's a ligamentous laxity.
Yeah. And that's why I said there's always a lag between what we know in research and what we know, in clinical care. And, if anybody wants some really good resources on this, look to the author Sinead Dufour out of Canada. She
McMaster, I think.
She's at McMaster University, but she works in a clinic called Womb, the World of My Baby. And there they intersect everything together. The physicians, the naturopaths, the doctor, the PTs.
It's very integrative.
Yeah, it's a very integrative approach. They have excellent outcomes because of it. But they're addressing things like, so if you're working with clients with this, find out how their sleep is. Find out what's going on in their life. Do they need some more support? What kind of support do they need? And I'm not, we're going to talk about the movement system in a minute. Please, I know we're all PTs and nobody wants to hear this other stuff, but it's so important. And so the common thing I always hear is there's never time to sleep. I don't have the ability to sleep because if one kid goes down, the other one's up. These things are happening, or, I'm having to breastfeed and, so I'm not getting the sleep that I need and I know it. And so and that's the case, that's real. But so I'll sit down with them and I'll say, tell me how the day goes. Like, talk to me about all of it. Like, what is happening at night? And so then we kind of come up with ideas and ways to say, and what I help her understand is, if you can optimize whatever sleep you're getting between 10 and 2, that would be ideal, because that's going to be the time that you can get the deeper sleep. That's when the human growth hormone drops in. That's when we get our deepest sleep at nighttime. And it really occurs between 10 and 2, which is why people get so screwed up when they go across time zones. Because our circadian rhythms are taken off, and it's hard. Even if it's an hour, it's still hard. So going 4 hours is really hard, and of course going across seas is crazy. But so perhaps maybe she can only get 2 hours of sleep, but can she get those 2 hours between 10 and 2?
10 and 2. Yeah, that's a good point.
Can we optimize? And so it's not shuttling them off and saying, oh well, poor thing. It's more like, what can we do?
Right. And so and so in terms of belting, what are the guidelines on that? I'm not familiar with that. I mean, I've used pelvic girdle belts for other reasons over the years, not for pregnancy related issues. So,
belting is like taping. It's like sensory input.
Yes.
It influences muscle activity by sensory input. So it might help switch the muscles on, or it might help inhibit some muscles. Here's the thing with it, though. The literature has been all over the place with it. And so when you have to look at the literature and grade it across, like for a guideline, it comes out as a pretty low score. And because they just belt everybody, and they don't really try to say who might benefit from belting versus others. The people who may benefit the most are the people who are probably the most acute in that kind of situation. Just because it's a reminder about movement, and it's compressive and it feels a little bit better. So that's in my clinical opinion. Now, other people may have other clinical opinions. Here's the reason that belts don't work: because nobody can sit down in them.
I know.
So they wear them for that's why I say acutely it works really well, because they'll put them on and take them off for a few days.
Yes.
And then it's sitting on the couch. It doesn't really help anymore. I
No,
can't
because it rides up.
can't stand it, don't like it. It's uncomfortable and they can't sit in it.
No.
So I really prefer them if they need some sort of compression, and that's going to be really helpful for them, that they get the kind of compression garments that will allow them to move and to sit and to move. And there's some beautiful ones out there. My whole thing is whatever fits the best, and gives nice compression, and you can wear it in pregnancy and you can wear it in postpartum. So, so you don't have to buy 2 different kinds of things and 3 different kinds of things. And if anybody wants to know which products I really like, you can message me, email me, Susan@ltiphysio.com. Happy to have a conversation with you about it. I'm not going to put it on the airwaves, but I think everybody kind of knows there's lots of really good ones, and they should be easy to go on, and they shouldn't interfere with breastfeeding. But I think that there's a place for them, just like, again, if sensory input makes them feel better, that's something that we're building self-efficacy with that. You try it on, you tell me how it feels, if it's comfortable for you, if it helps, and wear it. If it's not, let's keep looking until we find something that does feel better. They might do better in just pulling on a pair of pregnancy Spanx, and it's like,
exactly,
it just, and sometimes it's a sensory input that just tells the nervous system we're protected.
And I will tell you though, with this particular patient of mine, her sleep is a huge issue. It's always been pre-pregnancy. It's never sleeps well, does not sleep well. So I think that's the first line of defense. The first line of treatment, I should say.
And so working with clients, and I work with them to find out, show me how you get in and out of bed. Show me how you get what's uncomfortable for you in bed. Let's work on that. Rather than saying, here, just put a pillow between your legs. And, no, show me. Well, when I do this and this, okay, let's figure that piece out. That's working with the movement system. Most of the time, it's because they've been in one position for a long period of time. And then they go to move, and the discomfort, the pain wakes them up. And so when we do have some softening of the joints. I'm not saying that the joints don't change. No, don't quote me out there saying that. All I'm saying is that it's not dangerous, and the joints are not moving out of place, but they do soften, a bit. And so when you're laying on your back, it may be like a turtle trying to get off your back, because it's kind of formed into the bed a little bit. Same thing with sitting in certain positions or certain chairs. They may sink in a little too much, and then they have to work a little harder to get out of that position. So spending a little time and just teaching them things like, when you wake up and you need to move, what would make this better? So we play around with things like, what if you did some rocking side to side with your knees, like lower trunk rotation? They're on their side. Can they begin to just start to do that lower trunk rotation to move, to roll over? But can they do it in little smaller things so that they can kind of begin to move everything around and kind of get it going, so it's kind, and they can figure it out? Like, what would happen if you actually held your legs in this position while you move? Oh yeah, that feels much better. Good. Sometimes I will take a TheraBand and tie it around their thighs, and so that their knees are close together. But when it comes time to move, we'll just play with kind of pushing your legs a little bit away into the TheraBand to kind of like bring in the power of those pelvic muscles, to kind of wake everything up and like tell the brain, hey, we're working here, we've got this. And and they no one's going to sleep with TheraBand around their legs, but they can practice that during the day with many exercises that you can give them. You can give them lower trunk rotation with a TheraBand around their thighs. You can give them bridging. You can give them, all the moving things that they need to do, sit to stand, some monster walks, all of those things. And they're going to need that anyway, because they're moving into much more of a coronal based gait pattern, because their belly is like moving forward.
I like the lower trunk rotation with the TheraBand, because that is the issue, at least with this patient. So
absolutely, 100%. And then sleeping positions, like, show me how you sleep, what's on the table and off the table. They're not going to be able to sleep on their stomach after a certain point. They may be fearful that they're rolling onto their back, so there's that fear thing rolling and going in their head, because they've been told never sleep on your back. And So
Yeah.
like, well, let's problem solve that. Can we set some pillows in a certain way so that if you do begin to roll backwards, you'll feel it and you can adjust again, or maybe because of the sensitivity, you just need to get up and move around a little bit, and then go back to bed. It's really okay. You don't have to lay in bed and fight it and get upset and nervous and crazy,
Yeah. Yeah, no, it's interesting because we play with pillow positioning here, and she does go on her tummy still, but we have like we put little I have props. I put her in props, but I brought up an interesting point earlier is that people we know that we need to treat the person as a whole, but but when they're pregnant and they have been coming to see you for another issue, or not, you need to, we talk about those powerful questions again, right? So you need to ask those questions still and not just hone in on, yes, you're pregnant, but you have a nervous system that you've had since you were born, and that gives you the ability to cope with chronic neck pain or whatever other injuries they've had, and how long have they healed. And so those will all play into it, right? Obviously, because pregnancy is a beautiful thing, but it changes how you move and changes how you feel. And people who've had, like this patient of mine, definitely, poor sleeper, very highly sensitive nervous system, and that it's just going to get ramped up.
Right.
Now.
And we know that those are the risk factors.
Yes.
Exactly what you said. The literature hasn't really looked at neck pain prior to pregnancy, but it certainly has looked at back pain. And I can't believe that there's that much difference. For people who have persistent back pain, are definitely more at risk for developing pelvic pain, and so I would think that any kind of trauma might set people up for a little bit more of that fragile, wrong word, sensitive nervous system, or nervous system that's overprotective, at this point. And again, with pregnancy, there's a lot of agency around that abdomen and pelvic, region, a lot of thought process, everything's happening there. The whole thing is going on. And so of course, the spotlight's going to kind of be on that area, and the neurosensitivity, if that's the case, is can sit there. So I think one of the things to kind of think about when we talk about these clients is, it's really important, emotional well-being, sleep, and the stress response. But people can be positively influenced through individualized education, lifestyle, counseling that can empower them to self-manage their pelvic girdle pain. So when you can get them to see and ask those stories like we talk about with the powerful questions, then they can begin to see that, because one of the things that will be uncovered is something more like the belief system is that it's not going to go away. And we really want to have people understand and have the self-efficacy to know they can manage this, and that it's not dangerous and something isn't wrong.
Yeah.
And one of the biggest things to think out there for everybody with the movement system is, all of the literature that has looked at what we call, quote, stabilization or core stability or core exercises and all of that hasn't washed out very well in the literature. And the reason that it hasn't is because, once again, who would benefit from this kind of exercise versus this kind of exercise? But the two things that did show up and are really important is exercise, period.
Any exercise.
Yes, any exercise, so it's all good. It really, really helps reduce pelvic girdle pain, and maybe to prevent it, if it was already, if the exercise was started prior to pregnancy. So, kind of thinking about what's the minimum recommended activity, and, for maternal health and pregnancy is, one of the biggest things they talk about is walking. Walking is a great exercise. It can help people feel a little bit better if walking is painful. One of the things they have found very, very helpful for people is to get in the pool.
Interesting.
Aquatic exercise is the one that shines through all the literature. And here's the reason why. Water is compressive. Water is supportive. You can move in different ways in water that may be more difficult on land, but it helps people explore movement again and feel empowered to move, with less symptoms when they're in the pool versus out of the pool. And it can actually help them manage their symptoms out of the pool, because the more they do it, they get better and they feel
Yeah.
better and they have hope and they know it can change because it has changed. And so they, they're more likely to carry through on the other exercises and things like that. So
Yeah.
we want to emphasize behavior changes that will empower self-management more than anything with this population, because they're really at risk when we think about it. And, the cultural risk of, oh, everybody has it, too bad, it'll go away when you have your baby. I mean, all of these self-defeating kinds of
Yes.
words and phrases are so unhelpful.
Yeah, yeah, and a lot of times it doesn't go away,
Yeah. And then what do you
it's
do, right?
right. And I was telling my patient, like, she has 2.5 months left. I'm like, well, you don't need to live with this for the next 2.5 months. We should work through this. And you talk about movement systems and trying to get them to move differently and things like that. And I don't want to belittle it and say it's like another orthopedic patient, but it's not. But it changes how the person moves, for sure. It changes their whole movement system, right? I mean, it really does, since they're center of mass, base of support. And at the end of the day, a lot of people are just better copers than others. And as you said, first pregnancies and can be a bit what's the word? Could be fearful for some people.
Yeah, I'm anxious. You're
Anxious.
having a
Thank you.
baby, you're gonna push a baby out of your body, or somebody's gonna pull it out of there, or something. So people are, and rightly so. That's the thing. Is like, you know, for people to be able to have the ability to express that, I think is huge. And when they're in a supportive environment who's really listening to them and helping them problem solve and do that, they're more likely to actually talk about these kinds of things like, I really don't know what to do. I'm really worried about this. I'm worried about that. And it's like, that's the time you can step in and say, have you spoken to your physician about these worries? Or, what kind of support do you feel you need around this?
Yeah.
Because there's lots of people. There's, birth counselors, there's doulas that are really good at helping them establish a birth plan if that's what they're going after. If they don't feel heard in their OB's office, there's a million things that could be driving this. And most of the time people will tell you, I'm not stressed. I'm really excited about having my baby. And it's like, that's not the kind of stress I'm talking about.
Right.
I'm talking about the survival brain stress that isn't, that's keeping you living in cortisol and, not really being able to step fully into your positive emotions as much. They may still be happy people in some ways, but and tell you that they're not stressed until they start paying attention and they go, oh yeah, whenever this happens, this starts to happen.
Yeah.
Whenever this happens, this starts to happen,
Yeah. So what are some of the myths around movement in terms of this population? Go ahead.
So some of the myths around movement is that it's dangerous for people to exercise and raise your body temperature, that it's harmful for the baby. We've proved that that's not really true, that exercise is really powerful.
Yeah.
And you just have to listen to your body. And, if the exercise that you're doing isn't, you're not feeling it in the moment that you're doing it, but 2 hours later, you're having a lot of pain, it's time to start listening to your body and stop pushing. Because there's a time physiologically when maybe we need to back off a little bit. I know everybody always talks about the hero that runs all the way to the delivery room, but but that's an anomaly. That's not really what's going on. People really need to be encouraged to listen to their body and just know, okay, it's okay to do some high intensity interval training, but what are you going to balance that with? If we're talking about, cortisol and the stress response, maybe what you need after work is a nice quiet walk in the woods.
Right.
or a nice walk with your dog, or maybe your family at the park, or something that's calming, not crazy.
Yeah.
Maybe, another time of day when you feel a little bit more energized, you can go do that run. And that's fine. So just, so I think people saying, oh, reciprocal movements are bad, or, if they cross their legs, that's hard because that pulls the SI down. And we know that that's not true.
No.
That's just patterns of movement. So I think the biggest thing that we could do is help people have as much variance as possible in the movement patterns that are available to them.
Yeah.
In the first trimester, that's much easier to do. because
Mhm.
it hasn't really, there hasn't been a ton of changes other than, the normal stuff that's going on. And but the third trimester is where it gets a little bit trickier because they don't have it, it's harder to sit down. So maybe you need to say, perhaps you need to take off that really skinny skirt, and so that you can bring your legs apart to lean over to get out of a chair.
Yes.
I mean, there's got to be room
Right.
for the
It's the
baby.
baby.
Exactly. And I think, so people trying to just fit into their, into their regular world with, this body that's changing right now, and empowering them, like, maybe this is, I know you wear heels every day at work, or maybe they're working on concrete floors. Let's take a look at your footwear if possible and see if we can't get something a little bit more cushiony for you if you're on the
Mhm.
concrete floors. If you're in the high heels, is there a way, is it,
Mhm.
when you're standing at work in heels, do you have pain? I mean, maybe we need to think about what kind of classy shoe can you get that's gonna, like, maybe a wedge heel for you at this time, you
Yeah.
know?
Well, that's about the foot and the pelvis. We talked about that
Yeah,
so much. I mean,
yeah.
there is a huge relationship to it. I
Hmm.
mean, it, you know,
And the feet
I,
changes in pregnancy,
I was just
happen
gonna
too.
say,
Yeah,
yeah,
that
yeah, yeah.
happens too. And so, the same old shoes aren't going to work all the time, you
No,
know?
it's almost like you almost want to get people to think out of the box in terms of like, just don't, oh, pubic symphysis pain, your pubic symphysis must need a muscle energy technique to boom, 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 although back in the day, right?
And then it all
But
comes back as soon as they stand up and walk off the table.
exactly, exactly. And so let's look at how it affects your thorax or your feet, and let's work with that to see if we can make it better for you and get rid of your pelvic girdle pain. You just happen to be pregnant,
Yeah,
okay? It's the
yeah,
same principles in a way,
it is
but
very much so. Very much so. So movement system stuff is really important. It's just like what we would do with somebody with acute low back pain. How can we get them in and out of bed?
right,
The same things. We don't tell them that they can't go to bed. you
right,
know,
right,
we
right.
don't want them sleeping in a recliner all the time. They may have to for a day or two, but as soon as it starts to get better, we got to move you back into your normal movements in your life.
Mm-hmm,
And the
mm-hmm,
same with this is like, so because they're having pelvic girdle pain, they're like not hardly moving at all. And that's the
mm-hmm.
opposite of what we want. Is we really want them to feel empowered and unafraid that there is harm being done, so that they can move, because we do know that exercise is going to help.
Yes, yes. And even with my patient, she's, has a chronic neck issue and,
Hmm.
has fear around her neck. That's her
Hmm.
main issue. She doesn't have fear around her pelvis at all. However, when that baby comes out and gets delivered, that fear around that neck is going to be more, because she's going to have to pick the baby up and she's going to have to move, and and so that's that's going to be my issue with her. I believe. I don't think she has any fear around her pelvis at all. I think it's really around after birth, when she delivers and she has to pick the baby up, and that's her fear.
Hmm. Yep. And it
That's her fear.
could be too, like, what if this doesn't go away and I have neck pain and pelvic pain?
Right. Right.
Running in the back of her head, way back there. Those are the kinds of thoughts and feelings that
Yeah.
run that system. And of course, you come out and say, "Oh no, I'm not worried about it." But yet, in the back of their head, it's like, what? So
Yes.
being able to
Yes.
kind of just help people, bring voice to that stuff, I think is so important, and helping them really understand that this can change, and
Yeah.
that it doesn't require all this wild and crazy stuff, and it doesn't require, the emotional, uh, you know, the emotional lack of self-empathy, I think, is what happens in women. Many of their stories are they really think that they've done themselves in, or really have hurt, maybe even harmed their baby,
Mm,
that they've done
yeah.
something wrong. It's always, I've done something wrong. I did this to myself. I've done something wrong. And it's, no, you didn't do any of
Right.
this, and
Right.
that's where just helping them get that self-compassion, self-empathy back, and empathy for the situation is like, this is just this, this situation is such that, the kind of, maybe the physical demands from, your life right now, with being pregnant, with a system that's decided to be a little bit more sensitive, because the stress factors, gotten higher this time with this pregnancy, and this lack of sleep isn't helping either. And finally, the third thing, the last thing is, for those who are comfortable, it doesn't hurt to ask them what they're eating. This is the time to not, people are
Yeah.
having a lot of pain. Joe Tata says this quite regularly. Should I eat dairy? Should I eat gluten? Should I eat this? And he goes, well, how much sugar are you eating? That's where you start. It's like sugar is the biggest one that drives this stuff. And so,
Yeah,
you know, especially if they've got young children and it's a third pregnancy or even second or fourth or whatever it is, they're probably eating their kids' food. And
totally.
it's like, you know, so can they do something like, hey, what can we do nourish wise for you that can help you feel stronger and a little bit, you know, at least a little bit more resilient right now? You know, can you look at, you don't have to be a nutritionist. Can they look at getting like HelloFresh delivered to their door so that all they have to do is pop it in the microwave and they have a really good whole food kind of thing to eat versus, you know, kids chicken nuggets. You know,
Right.
kids are resilient, they'll be fine, but you know, it's
Yeah,
the
yeah.
adults that eat that junk that aren't fine. So, you know, kind of just, again, just some little problem solving. You know, what would keep you from having to stand in the kitchen so much? You know, if that's where it comes in, you know, because there's probably stress, kids screaming for food, husbands coming in, or wife, or, you know, partners coming in, and, you know, and they're just like, I'll just eat whatever, you know, and that's that's not helping either, you know, because then they're putting
No.
themselves last. So
Yeah, 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 yeah. No, this has been great. This
yeah.
is, yeah, I mean, this is, it's so funny because we, you know, everybody at some point in our lives has seen patients who are pregnant, whether that's your patient population or not, your ideal client, but you know, you just happen to be seeing them for something else. And I think it's important that we think out of the box as well, not just with anybody's symptoms, but just all of everybody's, right? And
Yeah.
it's part of the human movement system. It's just
Mhm.
not an isolated issue, right? And I do agree with you on the ligamentous laxity, because the people are still spewing that stuff, and the instability, it is all over the place.
A
And
bag of bones, I've heard it all.
yeah, I
You know,
bet.
and
I
none
know.
of, and they're all defeating words. They're not, you know, they're not
Yeah, not
helpful.
empowering.
Just not
No,
helpful. Yeah.
no, no.
So we'd
Great.
love your comments. Pop in, tell us what you think. And, you know, I know that there's a lot of other stuff out there. We're just talking strictly, you know, through the literature here. I know
Yep.
everybody treats pregnancy and postpartum a little bit differently. And there's a lot of, you know, massages and all kinds of things. Everything is helpful as long as it's empowering the patient.
Yeah.
That's the thing
Yes.
I'll say. I love
Yep.
integrative work as long as it's not passive.
Yep.
I want these ladies to step into their strength of character, of resilience, of importance, and not
Yeah.
feel like that something needs to be done to them and they've done something wrong.
Yeah.
You know,
Yeah.
it's just, you know, just really just working with the human system here. Thanks,
Yep.
everybody. We look forward to your comments.
Yep. Awesome. It was great. Enjoy.
Okay.
Also, guys, sorry,
Yep.
like waving my hand here. Also, if you guys are so inclined, if you really enjoyed listening to our podcast, we would still, I know we've asked this before, we would still appreciate it if you could leave us a review on iTunes or wherever you listen to our podcast. That would really help with the algorithm as well. So it'd be great. Just leave us a quick review on iTunes. That would be fantastic. Thank you very much.
Yes. And don't forget our membership, toughtotreat.supercast.com. Thank you,
Yep.
everyone. Have a great day.